Council. I'm very pleased to welcome you to our second session in this learning collaborative, um, Foundations and Sustainability of Nurse-Led Care. And we are going to be talking today about billing and coding for nursing services. And we were just chatting with everybody before we got started about how this is not an exciting topic for everybody, but we think it's an exciting topic for all of us. So we're very excited about to hear from our speakers for today. Next slide, please. I just want to review this disclaimer before we get started. This learning collaborative is supported by the Health Resources and Services Administration. However, the contents do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. Next slide, please. So if you have not joined us for the first session, and this is your first session with us, welcome. This learning collaborative is being organized by the National Healthcare for the Homeless Council and the National Nurse-Led Care Consortium, who we are so thrilled to have been working with to put this together. And we're very lucky to have two faculty organizations who are going to be joining us across all 4 sessions to share their expertise with us. And that is Colorado Coalition for the Homeless and Circle the City, which is from Phoenix, Arizona. Next slide, please. Just a quick review for anyone who was not here last time and just to refresh all of us. The Learning Collaborative is intended to be an active learning environment, so we do want it to be more than just a webinar. We have a big group this time. There was a lot of interest in this, and so in some ways that limits us a little bit in terms of interactivity, but we want it to be as interactive as possible. You may recall last time we asked you to think about some questions that you might have to be able to bring to our speakers. And so we just want to remind everybody to be present in the learning community, to be engaged and be mindful of other learners and that everyone is starting in a different place. Next slide, please. We are able to offer nursing CEs through the Nurse-Led Care Consortium, which is wonderful for this activity. It's 1 hour per session. And so to obtain the contact hour, you need to participate in the entire activity, complete the evaluation, and complete the assessment, the knowledge assessment, and get an 80%. So those links will be made available at the end. And if you have any questions, you can reach out to us. Next slide, please. Just our planned session. So we already did our kind of foundational session last time, history and current models of nurse-led care. We're going to be really diving in today, talking about billing and coding for nursing services, which we're very excited about. And then in our final 2 sessions, we'll be learning more about how to leverage program data and use the EMR to demonstrate impact of nursing care. And then finally, we'll talk about program sustainability, grant writing, and other funding sources. Next slide, please. This is our agenda for the day. We're going to do a quick Mentimeter like we did last time. We'll hear from Colorado Coalition for the Homeless and Circle the City, and we will have time at the end for questions. And if folks have cases, meaning like not necessarily an individual case, but thinking about cases for your programs in terms of nurse-led care, we'll have time for that. Next slide, please.
So with that, I'm going to take over. Thank you so much, Kate. Hi, everyone. It's Katie League. I am the Behavioral Health Manager at the National Healthcare for the Homeless Council. Great to be with you all again, and welcome to those who are joining for the first time. We're great to have you. A great question. There will be slides and recordings from both of these sessions made available. Apologies for the delay. The recording just needs to get onto YouTube before we can send it out, so those will be forthcoming. I appreciate your patience with us. As Kate said, we're just going to do a quick little round of Mentimeter. For those who are new, Mentimeter is a chance for us to hear from you without 51 people having to come off at mute at the same time. And so if you have available to you menti.com, if you are at a desktop with that 8-digit code, using the QR code, if you have a phone or a portable device, you scan it using your camera, or directly at the link that I sent in the chat should get you there. And so this is not required, just a chance for us to have some interactivity. So do not feel an overwhelming need to do this if you are listening and driving or listening from your phone. we understand and are happy to have you here. Thank you all who have found your way to Mentimeter. Love to see the variety of people here. We're thrilled to have you with us. In the next slide, we're going to get a chance to do that pin so we can see across the country, but love to hear a little bit more about your roles, titles, whatever hat you have put on today or just had to take off as you entered into this space. I know everyone in this world and the work that we do wears lots of hats. So really grateful to have you guys. Give it one more minute and then this is always a fun one, is to see the variety of
I can't tell if Katie's frozen just for me or for, okay, all right.
For me too.
I don't know if we're gonna be able to see the, this come up, so we might have to, oh,
She's unfrozen. There she is.
there we go.
I think it's Zoom. It was doing it to us yesterday. Zoom is being really weird. It kicked me off during our webinar yesterday too. It'll get back on.
There we go. She'll come back. So let me, just give me a second. I'm going to share the slides and then Teresa will turn it over to you. So hold on, everybody. You can just take a few minutes to.
I'm back, Kate. I'm sorry about that. I don't know what happened.
Yeah. Do you want me to share though?
Sure. If you wouldn't,
right.
If you have the ability to.
Yeah. Yep. Give me just 1 second and I will.
Let me see. I'm going to try one more time.
I'm almost there, but I'm if you
You're
can't,
good.
so don't worry.
There we go. Apologies for that, everyone. If you still have your Mentimeter open, there is one more question. How are you all feeling today? I'm feeling frazzled by my technological issues in that moment. So I should have added a frazzled. But we are excited and ready to go here today with you all. And I feel the heaviness of all of it. Thank you all. So without further ado, I am going to hand it over to Teresa from the Colorado Coalition for the Homeless. Teresa, thank you so much for being here, and I'm thrilled for this group to learn from you.
Wonderful. Well, thank you all for being here. If you want to get over to the next slide, these first couple should be pretty quick, I think. I am also joined here by amazing members of my team and our organization. So April Krall is here. She is our Director of Nursing, and you heard from her last week. And Andrew Grimm is here. We call him Andy, but he is the Chief Integrated Operations Officer, and he is here to oversee all of the amazing work that is going on, and he's also a part of the National Council as well. And then I am Teresa Helbig. I am the Director of Revenue Cycle, and I find all of this billing and coding stuff super exciting. So I am happy you guys are all here to join me for that. All right, I think we're ready to get into it. Okay, so the biggest thing, there's a huge myth that goes around, especially when you're in nonprofit work or when you're in nursing work or even case managers, that it's not billable, so it doesn't matter. This isn't meant for just towards nursing, but I hear it all the time, even with FQHC providers. It doesn't matter what we code because we all get the same rate anyway. And really the most important thing to know is that it's actually a myth. I try to not use billable as the term that I like to use when I am discussing these things. I would much rather use directly reimbursable. There are directly reimbursable codes that get us our rate, And then there are all the amazing services that you guys are doing that need to be coded and reported, because that's what supports the rate that all the directly reimbursable claims bring in. Without the support services that you guys do, those rates wouldn't be what they are. These services not only back up the rate that you receive, this allows for reporting for grants. It's getting you that higher organization rate. It's the data integrity that allows for the advocacy across the nation, actually explaining where your patients are at and what supports they actually need, what helps, what doesn't. How do we meet them where they are? There are just so many possibilities to utilize the codes for the services that you are doing. And it doesn't mean that you have to be like coding experts or anything like that. Just know that the work that you are doing is super important. As soon as you document that, coding will be your next step. But the codes and the services that you provide are incredibly important. If you want to go to the next slide. All right, this is kind of going to go into billable visits are not your lone ranger of revenue. Billable visits aren't the only thing that is going to bring in money for your organization. All of the support services happening in the background are that foundation for your directly reimbursable rates. Non-billable just means that you're not going to get that direct reimbursement, and kind of, I think the easiest way to think about it is how far along the spectrum of instant gratification are you on? Like donations, super instant gratification, right? Like you could spend that money right away. Then you have your directly reimbursed rates, which are a little quicker depending on which payer you're dealing with and what kind of loops you're going through, but that also pretty quick. All of the work that you're doing is the big picture revenue. And that is the justifications that are going in that support all of the work that is happening. All right, next slide. All right. I think it's very important when you're thinking about coding is to kind of meet yourself where you're at. Do you have barriers? Is coding super scary? Do you have supports that can help you through it? Is it the time it takes to document? What in your world would help you with more coding? Or is there something that you already know is stopping you? Documentation continues to be more time consuming no matter how we try to digest it. So how can that be made more efficient? How do we stay within regulations when we are making things efficient? But just know all of that time and effort, the payoff is worth it. Because the last thing we want is for you guys to do all of this amazing work and then no one actually knows that it's happening. Maybe your coworker knows, your boss knows, maybe even your organization knows, but we have to state your services in a way that the entire nation understands so that you continue to get the support you need to take care of the patients and to do the wonderful work that you are doing. All right, next slide. And that's where we get into your coding translation. Nobody wants to put their patients or their services that they're doing into a number or into letters, but really what your coding is doing, the reason the codes exist is to translate all of the work that you are doing into a language that payers can understand, that government agencies can understand, that other countries can understand. It is a universal language to where if I say 99211, everybody knows what service happened. If you use an E11.9, they know exactly what condition that patient has. So it is important for us to use that translation to the benefit of the organization. There are some nationwide codes that will have documentation requirements on a nationwide level. And just because you are not getting directly reimbursed, just because a claim isn't going out the door, doesn't mean that you don't have to follow the same regulations as if you were being directly reimbursed. And it comes back to the fact that is because we are using that universal language, and we need to make sure that we're all using the same things so that we can back up that universal language that we're using. Now, there are certain codes where states may make additional requirements for certain codes that are used, or maybe they have less requirements, or maybe they give you some loopholes, or maybe there'll be extra understanding. And that will be where you get down to your state level. But usually your state level requirements are more reflective in the directly reimbursable world. The nationwide codes usually have pretty much the same guidelines that you would utilize for the services that you're providing and how you translate the work that you're doing. So I think we can go to the next slide. All right. So now I'll give you some of the technical jargon just so that you leave here and you can be like, I did coding stuff today. And that is going to be, so these are all the stories of what you are doing. This is what I did within this visit today. This is the important work that I am doing. A CPT code is going to be a 5-digit code that says this is the procedure and the service or the test that I did. These are nationwide codes, usually have pretty much the same requirements across the board unless your state sneaks in some extra things for you. Now, the HCPC codes is how we say that cool little combination of letters there. Is the same thing as a CPT code in the way that it is still reporting services that you are doing, but this is like your medications, your supplies. This is where your payers can determine even more of what that service is doing. There's usually a lot more flexibility within your HCPC codes than there would be in a CPT code. A really good example of that would be, for those of you that do behavioral health care work, a 90832 is a 30-minute psychotherapy session. In CPT world, that means that a treatment plan is required for every single visit listed within your documentation. You have to hit like 16 through 32 minutes of time directly with the patient. You have to put what interventions you did, how much time like exactly you spent with that patient. Like there's certain requirements. However, the HCPC version of that may give you an option to only have to spend 8 minutes with that patient because you are just touching base with them and maybe it's not full-blown therapy and you are just having like a crisis conversation to make sure that they get the help that they need. That's an H2011. Still kind of the same service, but it gives you different guidelines on how to work within it. So that's kind of the difference between those nationwide codes. And in case any of you are super curious or if you work with any encoders, these change January 1st each year. And there might be like codes that are trying to get in that could be announced within the year that you can kind of use but haven't been made final. But all of those codes change finalized by the beginning of the year. So if you have any teams coming at you telling you that you have to switch up what you're doing a little bit, know that that usually happens in January for those nationwide codes. Next slide, please. All right, here is a coding example for a CPT code. So a 99211 is an evaluation and management CPT code. You can use this for nurse provided care. And you will see here that there are documentation requirements in order to use this code because it is one of those nationwide codes. You have to make sure that you are documenting the medically necessary requirement of the services. This is usually the patient telling you, this is what I need to be seen for. That is the easiest way to look at it. The appropriate clinical history needs to be documented. Your clinical exam as relevant to what you are seeing that patient for. And your medical decision-making within your scope. So you wouldn't be using somebody else's medical decision-making. That might be where you start getting into lines with co-visits and that kind of thing that I believe will be covered more so here later. And then the proper supervision and physician orders if you need it within your scope for that visit. And it is really important, even if your documentation doesn't hit that 99211, that you have another way to code any services that you're doing so that you can track it. It's not very nice to the code, but here in our organization, we call them dummy codes. Meaning I did a visit, I need to track it. Maybe it didn't hit the documentation requirements of that nationwide code, but I did a service and we have internal logics that we use. So we know what happened in that visit every time we see that code. Which also means that we can justify to outside funders, this is how many times we did this visit. You guys don't recognize this as a needed service yet, but this is how we're tracking it, and this is the benefit you can see from providing those services. And just in case everyone wants to hear the super boring compliance part of it, that you usually have other people to worry about for you, HRSA does usually require that if you are reporting codes to them like a 99211, that you have something in place to make sure that you are using it at that nationwide level. They want to make sure that when I say I did a 99211 nurse service, it is the same exact thing as if April reports that she did a 99211 service. Just making sure that we keep that integrity of that nationwide interpretation and translation of codes. All right, next slide, please. All right, here are some direct reimbursable opportunities. Again, a lot of times that's called billable in a lot of organizations. I still don't like that word because I think everything is billable if in some part of the picture. So co-visits, chronic care management, incident to physician services, these are all options. I think we all have different terms, but there's a lot more opportunities out there as well. So co-visits, maybe it's something where your nurses are seeing the patient, but then it needs to be escalated to a physician or a non-physician practitioner that is considered to be directly reimbursable for your organization. Maybe that is a wound that has become super infected. You need to escalate that over to the provider. Or you're seeing a patient maybe for the wound care, and then they're like, well, I've been having heart palpitations and these other things. Actually, hang on a second. Let's see if we can't get the provider in with you as well. That is still a nurse-initiated visit. You are still helping with that directly reimbursable rate, and you're taking on a majority of that initial work. The medical decision-making is still happening by the physician or the non-physician practitioner that you're allowed to get directly reimbursed for. And that's what allows the direct reimbursement, is the fact that the medical decision-making is happening by that billable provider. Chronic care management is kind of the same thing. It has to be overseen by your directly reimbursable provider, but you can know and back up all of these services, even with the nurse, the case management, all the support staff can help support that being a service that can be directly reimbursable. It just has to be under the oversight of that directly reimbursable provider. Incident to physician services are kind of like you taking the direction of that billable provider or the directly reimbursable provider. You're under their direct supervision. You got someone in the building, but you are doing those services for them. That is considered incident to. Can be a little risky if you don't follow the regulations, because that is one of the things that they absolutely look out for. That's one of their too many people took advantage of that and didn't follow the rules, so now they're keeping an eye on it. But if you do it right, absolutely an opportunity for the directly reimbursable funding and the revenue. Next slide, please. All right. It looks like he's worried about coding, but really he's just not feeling good. So ICD-10 coding are your diagnosis and condition codes. This gets to be the story about your patient. Why is your patient there? What are your patient needs going to be? This is how You communicate the medical necessity of the services that you are providing. Not that your patient is a combination of numbers and letters, but this is taking that language and making sure that you're translating that into something that your funders can understand. We always hear everyone say, well, your patients aren't that sick, you don't need it. Or we are telling them, our patients are so sick, this is why we need to do it. So this is where you want to make sure that you are telling the entire story of your patient and you're telling it as accurately as you possibly can. It was probably one of the most exciting things that happened in a very long time when we came out with the CEDO codes, so your social determinants of health codes. This actually backs up other conditions that could be affecting the condition of your patient. This is your homelessness codes, like not having access to food, coming from poverty, like actually explaining the whole story of where your patient is at. Now, these codes will change in October every year. So if it seems like they just annoyed you in October and now they're annoying you again in January, that's because that's what the nation is doing for you. Next slide, please. Here's just a quick ICD-10 coding example. So again, the story of your patient where you have the opportunity to tell the full story. A little different within nursing, you do have to make sure that you're staying within your scope, but this really comes down to the documentation. If you document the full story, we can normally help to, like your coding team or someone like a professional can help you to make sure that you're getting the most specific codes out of what you're documenting. I am a big believer that the people, all of you that are providing the services, just need to worry about documenting what you did, and the coding can be figured out on the back end from people like us that will nerd out on it, and then you guys don't have to worry about it. You can just see your patients. Okay, so like E11.9, type 2 diabetes without complications. Usually one of the easiest boxes to pick within an EHR. They got 2 diabetes, but like nothing's falling off. They're good. This might actually not be covered by some of your payers as a directly reimbursable rate. This also looks like to a lot of funders, their type 2 diabetes is good. They've got it. There's not really a lot of combinations. That patient is okay. E1142 is a bit better because that's saying, hey, they have diabetes too, but they're also having polyneuropathy. This says that, hey, this patient does have this condition and it is complicated by this other condition. So they're probably going to have to see me a little more because I'm not just going to be treating their diabetes. I'm going to be treating some other symptoms. And this will like back up pain management and all of those other good things that may come with it. That is backing up a fuller story of your patient. Now, to add on to that, just as an example of making sure nothing is missed, this is a social determinant of health addition where you say they also have food insecurity. It's really hard for them to be able to control their diabetes if they don't have access to the proper diet in order to do so. So that's just making sure that you're closing the loop and telling as much of your patient story as you absolutely can. Next slide, please. All right. And then in ending, you guys are the hero of so many stories. Your codes prove it. Just make sure your documentation backs that up too, so everyone can see the amazing work that you're doing. That's it for my end.
Thank you so much, Teresa. That was really wonderful. I did see someone put a question in the chat, and I think what we'll do is hold questions till the end so we can do them all. We're definitely going to have some time for Q&A, but I've made a note of it. So with that, I'm going to turn things over to Circle the City and to Christiana, who is going to talk a little bit about their nurse-led care work.
Hi, good afternoon, everybody. Hopefully everybody can hear me and I'm not frozen. As we know, nurse-led anything takes a team. The team is on the slide here. I couldn't do this without standing on the shoulders of Margarita, Tara, and Michael, especially Tara, who used to hold this role as a care coordination RN before I did. Next slide, please. And this is our mission statement. I'll give you just a couple seconds to read that. We focus primarily on unhoused and marginally sheltered populations. Next slide, please. So the origins of the care coordination role. This was by the time it came to me, it was grant funded for 1 year. Originally really shaped and held by Tara, who's on this call. She's now a program manager, at one of our respite facilities. My role this year was really to turn a care coordinator nurse role into something that was sustainably revenue generating within this year, while still providing all of the needs of our patients along their continuum of care. The provider support visit is what we have named our co-visits. The goal with those visits are to close care gaps and to improve our patients' care. Next slide, please. So we have a three-pronged structure. I sort of have three roles of the care coordinator, and that is to reduce hospital utilization. So we have a system in place for that. I won't talk about that. I'm really focusing on the provider support visits here. And then to close our patient care gaps. So the idea is that with a provider support visit, we can actually touch on the other two prongs. The more we stay in touch with our patients through provider support visits or PSVs, the fewer times they're going to the hospital, because we can catch things before they turn hospital worthy. We can stay more abreast of their care gaps, help them get preventative screenings and treatments that they need. Next slide, please. And I think I just said that whole thing on the last slide. The real goal is to keep those provider support visits as really the anchor to the care coordinator role. Next slide, please. So for us, what is a provider support visit? It is very similar to a co-visit, with the exception that we actually anticipate to convert the appointment. So these are nurse-led patient intake. I'll speak personally. I do a patient intake, a nursing assessment. I will take any detailed relevant HPI. I will actually throw orders in to an A&P. However, obviously the provider, once I as the nurse hand this off to a provider, I staff that provider with very specific language around the A&P to say, hey, this is what I think is going on. I threw those orders in. Obviously, it is not within my scope to sign those orders. I can't sign those orders. And then the provider moves on to see the patient. So we focus on single subject visits. So these are very much chronic diabetes follow-up, hypertension follow-up. How is that med working? Diabetes, how is the sliding scale working for you? Follow-ups that still absolutely should convert to a provider. But the nurse can start and establish the bulk of that visit. Wound care is another focus of ours. We have a thriving wound care clinic. And it's our actual wound care doc on Fridays has sort of become our daily wound care doc, because that clinic has become so popular. So speaking of the fast tracks, we call them PAPs, care gaps, and STIs. So we focus on women's health, care gaps, which is just our quality metrics. I'll show you some examples of that. STI, STDs, and then we actually do a results clinic. So we encourage people to come back specifically on a day, and all we do is just go through results. and the care coordinator nurse, which is me, go, tease everyone up in much the same way and just make sure the results are in the charts for the providers to review. So the way that this can work is that I would spend about 20 minutes with the patient, really getting in there, taking detailed history, making sure results are current, just checking to see if there's anything that a provider may want to order. And then that allows the provider to come in and have, after they've been staffed, a more abbreviated, yet still a required billable event, and then allows them also to save time on the charting portion after the fact. Next slide, please. So goals of the PSV, pretty straightforward. If we can see more patients, we're going to decrease wait times in the lobby. A big focus is to see an increase in number of patients every day, mostly because we have gotten to the point where we're turning away folks on the wait list every day. Helping providers close their charts on time, and hopefully taking a little bit of the stress out of the provider's day with kind of a wing woman or a wingman on the side. What the biggest challenge we have with our provider support visits is provider buy-in. I'm happy to address that in the chat or questions on the side, but we have some folks who are skeptical of someone else starting a chart for them, etc. Next slide, please. So the anatomy of a PSV, just very quickly, I wanted to show you some examples. This is an HPI. This is a template, or these are two templates that I, along with the medical director in my clinic, we worked out together, such that she would want to see, and any of her providers she would expect would be able to address on a visit. And so we work these out together. What I do, they're now dot phrases or macros. I dump them in as soon as I start a chart. If this is for hypertension on the left, I will dump that dot phrase in and I will start filling that out. And so it really becomes templatized so that any provider doing a chronic follow-up visit will know what to expect in the visit. Next slide, please. And the last one, I just wanted to show you, whoops, if you can back up real quick. This is one of our care gap clinics. This is an order set. So this macro will both dump an HPI in for me and dumps an order set in for A&P. So what is missing on there, I couldn't make it fit on the slide, is colon screening is in there, but this will dump a standard order set in for the provider. If I know this person, I can see the quality metrics in our EMR. I know this person already had their flu vaccine. I go in and just delete these things out. So this is the largest that the order set would be for us, with the exception of colon screening, which should be in there. And then I remove things or add language in there as the visit unfolds. Next slide, please. So the billing, so I know 4 codes. I know 99211, 99212, 213, and 214. That's all I know. As a nurse on my own, I'll do a 99211. If it becomes a provider support visit, our providers are the ones who decide that this is a 99212, 2, 3, or 4. I can say most of these visits are landing in the 212 and 213. And most of them, I think, are being billed as 213s, but don't quote me on that. That is not my expertise. So you can see here on this slide what we're hoping to attain, that if every CCRN was doing 2 of these visits a day to help a provider, those are 2 extra billable visits, and that adds up pretty quickly with the end slide there. And I believe our last slide is the thank you slide. Thank you so much for this opportunity.
Thank you so much. These 2 presentations have been wonderful, and I think they have complemented each other so well. So I see a few questions already. We thankfully have plenty of time for questions, so I'm gonna these questions. And I just want to say, I think this is so valuable, and healthcare for the homeless is such a great setting for these types of nurse-led care initiatives, because we have so many ways and places that we work and interface with people. And, although nurses may need some training to understand the codes and the workflow, all of this is part of nursing, and this is within our nursing scope of practice to do this work. Um, and I have seen this done in lots of different ways, kind of in different health centers. So many health centers use the model that Circle the City is using, for having a nurse have their own schedule and then kind of pulling a provider in. Some places are lucky enough to have a provider who they can give like a light schedule for the morning, and they know that they're taking nurse walk-ins and nurse visits that whole morning. And that way there's a provider who's more available to come into all those visits. Some places will have a nurse who's the person who does visits, but also triage throughout the day. And they also just kind of like, as they can, grab other people. So there are lots of ways to make this happen. And I do want to say, NNCC and National Healthcare for the Homeless Council are here. If you have additional follow-up questions, we can follow up with our faculty. If you need more help with this, we're happy to step in and give you some more ideas and assistance. So we're at the end. I just want to say we have 2 more sessions. They're the next 2 Thursdays, the 20th and the 27th. We're going to hear more great information about how to do this work. So thank you so much to our speakers. This was so valuable, and thanks to everybody for joining us.